I have the pleasure again of introducing Dr. Weisbart. So he is the National Board Secretary and Missouri Chapter Chair for the Physicians for National Health Program, a nonpartisan nonprofit organization that supports single-payer national health insurance. So again, Dr. Weisbart is an experienced retired family medicine physician who practiced for over 20 years at Rush Medical College before he moved to St. Louis in 2003 to serve as the Chief Medical Officer of ExpressScripts. During that time, he also volunteered as an assistant professor of clinical medicine, Washington University in St. Louis, and then also also served as the president of the Consumer Councils of Missouri. Thank you very much for coming back to us, Dr. Weisbart, and we look forward to hearing about pharmaceutical formulary today.
Well, thanks, and thanks for inviting me back. So, you probably have heard allusions. I know you've heard allusions to the fact that I was chief medical officer at ExpressScripts, which is a pharmacy benefit management company. You might be wondering how that happened, and we'll talk a little bit more about that, I think, at the end of later on this morning. But the reason I'm bringing it up now is because you might be having the same thoughts. So I'm a family medicine doc. I'm interested in healthcare reform. I like big principles. I like family medicine. I like treating the whole patient. So when ExpressScripts called me and said they wanted me to be chief medical officer, I didn't know what a PBM was. I mean, I literally didn't know what that was. I didn't know where St. Louis was. I didn't know any of this stuff. And the idea of focusing, from the biggest of pictures of healthcare reform to, the patient level to just the pills, really just the pills. That's all we're going to be talking about it was not a natural fit for me. And then I started thinking about the fact that it was just the pills, but it was for, at the time, 47 million people. And now it's, I don't know how many millions more it is now. So there's that. And the thing that's really interesting to me about the pharmacy benefit is that there's real ungameable data that you can learn things from. So you can, there's a lot of leeway to decide what diagnosis, what ICD-9 code, maybe even which way to categorize your CPTs. There's a lot of, but pharmacy claims are pharmacy claims. You may not actually know if the patient is taking the pill, but you do know rock solid for sure if they filled the prescription and how often they filled it and what they got. There's no gaming to that part of it. So it intrigued me that there's lots of data and you can make informed decisions. So anyway, that kind of lured me in, and the idea of working on policy for, at the time, 47 million people was just irresistible. So here I am. Now I spent 7.5 years in that industry and learned more than I ever thought I would want to learn. But there's some really important stuff, and I'm delighted, by the way, the internship has been set up because you've had a few pieces of it. You're going to have much more the rest of this week. And I'm kind of in the middle, not quite in the timing that it ideally would have been in the sequence of things, but that's my fault and not Marvin or anyone else's. It's because my schedule is pretty hectic right now. So, but there's some things that I really want to share with you. So that's why we're here. And depending on the timing, expectation is that we've got another little segment, if I can make time, if I can stop blathering, another little segment to get to this morning before I run off about how to speak with legislators, and that'll be brief, but I do want to try to squeeze most of that in here too. So that's what the plan is. And I want to start with this. Does anybody know what she might be bothered by if you look at her? You can speak up. What do you think is bothering her? Okay, it's too early for you too. I get it. So menopause. Okay, this is supposed to be a picture of a person going through menopause. And the reason I'm bringing that up is because there is this drug called Brisdell. So raise your hand if you've heard of Brisdell. Good. That's my bias. Good. So, but Brisdell is the first and only FDA-approved non-hormonal treatment for the symptoms of menopause. And menopause can be small, medium, or large. It can be so trivial subjectively that you don't even know you're going through it, except that you don't have any periods anymore. Or it can be so extreme, frankly, that it's disabling. And there's a whole spectrum of how severe the symptoms are. So, a treatment for it, for the symptoms of it, is actually potentially a really terrific thing. So hooray, there's a drug now that actually has the FDA listed approval for that, without having to deal with estrogens and all of those controversies. So what is this wonder drug? Well, first, how expensive is it? So it's 7.5 milligrams, and it's $232 a month. I looked this up a few days ago. $232 a month. Probably worth it if you're having severe problems. But hooray, its patent has expired. Now you can get generic Brisdel for just $53 a month. So there's a lesson. Patent expired, price came down, and I'm sure you'll hear a lot more about that. But what is this drug actually? It is paroxetine. Now that you've heard of paroxetine, or the brand version of that is Paxil. It's one of, I don't know, a dozen or so antidepressants that came out 30 years ago or something like that, like Zoloft and Prozac, and there's a variety of them, each slightly different, but there's a variety of them. I mean, paroxetine is one of those, and it's been on the market for decades, so you can buy it as a generic. And you can buy for $19 a month, probably less in some places. So how can brand Brisdel come to market for $232 when generic paroxetine's been on the market for decades, for literally an order of magnitude less in price? The secret, of course, is in the milligrams, right? Because when Paxil was out as a brand drug for depression, it was available as, I think, 5, 10, 20, 40 milligram pills, never in 7.5 milligram pills, because how much granularity you need on the dosing. It's not like Coumadin, it's not that specific of a dosing requirement. So I would submit to you that there's really no clinical basis to think 7.5 versus 10 milligrams is different for almost anything, but certainly not for the symptoms of hot flashes. But the key, of course, is that if I write a prescription for brand name paroxetine, Paxil, for 10 milligrams, the retail pharmacy can dispense the generic paroxetine, of course, without calling me. If I write the word Brisdel on a prescription, even if I write May substitute, then they can get the generic version. But before that, before the generic came out, which is fairly recent, if I wrote May substitute on Brisdel, they couldn't, because it's not a milligram to milligram equivalent. Now, this may be my cynical take on the world, but I think that's the reason they came out with 7.5 milligrams, so that they could have this market niche. And that's just one of many gambits, right? 7.5 milligrams. Really? Okay. So that's just one of many gambits that they have. So PBMs, get back to the topic, were designed to encourage the use of things like the 10 milligram paroxetine. That's sort of the basic philosophy that it was established with. And I'm going to show you that that's not quite where it's landed at this point. But the origin story is pretty good. The origin story is, noble fighter, and maybe and that's where I got in, was in the step, before I showed baby Anakin. But so it's, there's sort of a pretty good origin story, and then of course it has changed, and now it's, I would argue, quite a bit different. But maybe that's unfair. I don't know. So I'm not going to do the whole history of PBMs, but the apocryphal image of that is that there was a time when pharmacies would submit their bills to an insurance company through the U.S. mail. And then the upgrade was they would send faxes to the insurance company for reimbursements. And that's kind of where PBMs really started to take off, was to try to collect the insurance companies and the pharmacies electronically, serve as the electronic intermediary. And there's an apocryphal story of my PBM's founder, Barrett Tone, driving around in, like, I think, a Volkswagen or something, with paper bills like flying around the inside of the car because it was so chaotic compared to the improved system of electronic systems. So that was, helpful. Pharmacies could get paid much more quickly. And then it wasn't just that they could get paid. Then PBMs realized that they had data, because they were now the intermediary in the prescribing or in the dispensing process. So they had this data, which is really valuable. And so again, still in the Anakin Skywalker phase, they were able to use that data to come up with tools that would indeed lower the cost of drugs, right? I mean, at this point, there were so they could do that. They could come up with tools that were clinically sound and would make the use of prescription drugs more affordable. Great. And then as they became more and more enmeshed in that, they became really indispensable to everybody. The pharmacies were relying on them. The insurance companies were relying on them. And so they began, I would argue, right after I left, leveraging their value in ways that I'm not so sure are I'm not so sure are appropriate. And then they became so successful at that the insurance companies decided that they really wanted a bigger piece of that, didn't want to be their clients, but wanted to own them. And so they became integrated. So that's my sort of story arc of how the PBM origin story began. And you're going to hear more about it. But here's where we are today, with these PBMs make up almost the entire market of PBMs, and they are no longer independent. They at one time they were almost all independent, freestanding, no conflict of interest, sort of other than their own personal interests. And over the last 20 years, they've become owned largely and owned now insurance company related, and indeed many of those systems are linked to specific medical groups that the owners own. They typically now own their own, or maybe contract, but almost all own their own mail order pharmacy, which you could argue might be a conflict of interest, but maybe it's an economy of scale. Mail order pharmacies are cheaper and I would argue safer, but having the insurance company and or the PBM own it is peculiar. And then it's got a whole other layer of complexity that now they sort of offshore typically their rebate structure and stuff, so they can hide even more of their proprietary information and skirt even more taxes, and just make it even more complicated. This whole gamish of things now often owns their own private drug labeling, so it's pretty hard to unsort this. Good news is Shannon Rotella is going to speak to you, and she'll unpack all this, have it all be more clear. And I can skip unpacking that because I know she'll do a brilliant job. So instead, I'm going to focus on the formulary piece. They develop formularies, and every insurance company has their own. Every PBM has its own, and the formulary basically is a list of drugs that will tell you what or how much an insurance company will pay for a drug. And then also the formulary determines how much the patient has to pay for a drug. So if you're getting your prescription drugs through an insurance company, it's probably using a pharmacy benefit. It's using a pharmacy benefit management company that determines how much patients will have to pay. Problem is, there's a whole lot of these. So the insurance company, there are 1,000 insurance companies, 66 PBMs, and each one of these has a whole array of formularies. So, there are, I don't have a count of it, but there are probably tens of thousands of formularies. So when you're in your office trying to know which drug is on your patient's formulary, good luck with that. Good luck with that. It's trial and error. The patient will complain to you that the drug costs too much. The pharmacist will say, try something. It's a whack-a-mole game. It's craziness. So that's, I would say, wildly out of control. Why do we have this? They determine power. And there are three basic structures to formularies: open, tiered, and closed. They recommend a spectrum, and there's pieces in between. But to simplify it to these three, an open formulary includes every drug that's on the market, and with the same copay. I'm making this an extreme version, but the same copay for every drug. So you want Enbrel or you want aspirin, $10. And of course, if you have that, then it's the market share of each drug is based on the television ads and the ads in journals, and trying to, it's the market. It's the PBM doesn't have any influence on the market share of a drug, doesn't have any ability to try to support driving to the lowest cost drug, doesn't have any ability to negotiate, and doesn't have any rebates, discounts, anything of the sort. So they, it's kind of a limited power, and they're not really in the power situation. They're almost like an intermediary, an ASO almost. Then there's that's an administrative services organization. ASO is administrative services. It's a form of not health insurance, where there's no real insurance happening. It's just sort of a pass-through of the administrative functions. So that's what an ASO is. Then there's a tiered formulary, and this is what you're more familiar with. It's more common. It's almost everywhere. This is where there are 3, 4, or 5 uh, tiers in the drug and in the formulary, and the lowest tier drugs, tier 1, would be the least expensive, and the highest tier might be the most expensive. So the intention of this is to encourage consumerism, to encourage patients to want to go to the less expensive drug for whatever reason you pick, and we'll unpack that in a moment, and likewise influence us prescribers. But understand, of course, that we have no idea what the patient's formulary is. We have no idea which drug. All the studies looking at our ability as physicians to estimate the cost of a drug for our patient, be it either the retail price of the drug or the copay, they show that we have absolutely zero predictive power on that. So it's trial and error, basically, maybe influencing the patients to do it. So that's why these tiered formularies have some efficacy at driving towards less expensive drugs in the ideal situation, even when it's not corrupted. But it's not powerful movement, but it's some movement. So modest impact, and because of its having modest impact, the discounts and rebates and such are modest, not striking, but enough to make a business case for people to corrupt. Then there's the closed formularies, and this is a formulary where the drug is covered or it's not covered. It's kind of black or white. It's binary almost. And if you have that kind of a formulary, you need to have what the business people call a BATNA. You know that acronym, BATNA? They actually use it as they say it as BATNA. It's not Batman, BATNA. It's the best alternative to a negotiated agreement. A BATNA is your best alternative to a negotiated agreement. So if you have a closed formulary and you're trying to negotiate the price of the drug against the manufacturer, you need to have an alternative to their drug, or the other side of the table knows they don't care what we say, you're going to have to cover the drug. If you've got like this one unique drug, you're the manufacturer, and you make this drug that saves lives in a way that no other drug can, you can charge what you want unless the person on the other side of the table has an alternative. So you need to have it when you're going into a tight negotiation. You really have to have a BATNA, a best alternative to a negotiated agreement. You need to know what your BATNA is too, so you can make your trade-offs. That's obviously not unique to formularies. That's true just in business writ large. If you have a closed formulary, drugs are on or off. I promise you, it's impossible to design a formulary other than the USPS. It's impossible to, United States, no, other than the entire pharmacopoeia, it's impossible to make a formulary that actually meets everybody's needs. And so if you do have a formulary, be it under single payer, be it under United, be it whatever, you must, in my mind, include exception criteria. And that's not hard to do. There's tons of ways to, there's tons of ways to really kind of flesh out, we don't cover this drug unless it's these clinical situations. There's really great evidence-based ways to do that. And those evidence-based ways to do it can cover 99.9% of people for whom the formulary doesn't fit. And then you need to have an exception to that, where there's actually a humanoid at the other side, a physician ideally, who can, we didn't think of that. Okay, so I'm saying this because not every insurance company, not every employer that picks a formulary, not everybody includes exception criteria. There are a boatload of employers around the country who take the formulary as written by the PBM or by the insurance company and reject the notion of exceptions. And part of my job when I was in the PBM industry was to try to persuade them otherwise, because I knew how good and bad our formularies were. But so I'm just making the pitch that if we get to the point where we're designing a national health insurance formulary for the country, we EGAD, either have to cover every drug, which is what some people say, let's just cover everything for everybody all the time. Well, then you've got the problems of the open formulary, no negotiating power, no discounts, the prices would be uncontrollable. Instead, if you're going to have a restricted set of benefits, which of course you would have to do, they need to be medically appropriate limits, but you're still going to have problems that you didn't anticipate. So there have to be exception criteria. And my pitch to you 25 years from now, when you're designing the policies that we all need, remember that you're not going to design a perfect system. So you have to have an escape valve. You have to have exception criteria. Again, I'm talking about formularies, but it's true for everything. You need to have a system for the population and then an exception process for the people for whom that just doesn't work, and that will happen. So this approach, a closed formulary, is the most potent way to move market share and gets you the largest discounts. So as of last year, this is the most common approach to formularies. Were tiers 1 through tier 5 that you can read right there, and you're probably familiar with tiers 1 and 2, and then it gets more sophisticated as it goes on. Here's the average copay in 2023. So as you can see, it's designed to move market share. If you are trying to fill a $66 drug, you would probably be motivated. Most people would be to try to find that $11 drug. And then some insurance companies or PBMs don't use co-payments. A co-payment is a flat dollar amount. So every drug on tier 1 is $11. Co-insurance is where you pay a percentage of the cost. Whatever the cost is, you pay a percentage of that. So 20%. The advantage of that, of co-insurance in theory, is to more engage people in the real price transparency stuff. The disadvantage is then you have no idea what the drug's going to cost when you go to the pharmacy. You have no idea. You're going to pay 20% of whatever the price is, and who knows what the price is, and who knows what calculation they're going to use. So co-insurance maybe makes sense, but it's really complicated and hard to understand. And then, so it turns out that co-insurances are becoming more and more common on the more expensive drugs. That's a whole topic of itself. So you can use formularies if you want to be mercenary. You can weaponize the design of a formulary to not have to have sick people. So if you think of it, here's a list of drugs from this particular study that looked at that would probably attract sick people, right? If these drugs are well placed on your formulary, you're going to people who are really sick and are shopping around and comparing you to another insurance company will want an insurance company that covers these drugs. You don't want those people, right? You don't want those people in your insurance company because they're expensive. You can't, there's not as many of them perhaps. And so there's a smaller population. You can't predict the risk as well. One year they'll be expensive, one year they won't be. So these are the people that you don't want in your insurance company if you're only looking at your bottom line. And so not every insurance company covers them as well. Or if they do cover them, they put them up on the 3rd tier. Notice that Plan 3 at the time this was done was actually Harvard Pilgrim. So you can weaponize formularies, and believe me that they do. Okay, how are formularies built? And this is the sort of the typical process. First is establish categories of clinical drugs, so like all the ACE inhibitors. I've been picking on ACE inhibitors lately. Let's stay there. All the ACE inhibitors are in this bucket, let's say. And then what you want to do is find a way to compare the drug's clinical value in their category, and then consider the economics, and then consider the market. So here's in my little cartoon, we have decided that drug A has the highest clinical value for any of a variety of reasons. It might be the most effective. It might just have the best data around compared to little tiny studies for drug C. So by any array of things, and we've determined, let's say, that drug A is much higher clinical value than drug C. And then you've got to look at the price, right? The relative cost. And so in this example, drug C is really a loser, right? It's got it's got lowest clinical value and highest cost. So who in their right mind will put drug C on their formulary? We'll get there. And then you look at market share, and in this happy example, drug B has the market share. And the reason you have to care about market share if you're a PBM or an insurance company is because if you take a large market share drug and don't put it on your formulary, number one, you'll annoy your patients. And number two, if you actually don't put it on your formulary, then you won't get any discount at all. So if you have a closed formulary, right, if you have a closed formulary, that's fine because you're not going to pay for the drug at all. If you have a multi-tiered formulary, however, your patients can still go to get the non-preferred brand drug B, and they'll pay, what did I say, maybe $60 for it. But non-preferred brand drug B might actually cost $300. So you're paying for a $300 drug, patient pays $60, you pay $240 as the insurance company. So if it's not on formulary, that means you're paying that $240. Whereas if it's on formulary and the PBM can get you a rebate or a discount or what have you, maybe instead of paying $240, you'll only pay $200 or $150. So that's why market share is a consideration for everybody other than closed formularies. Closed formularies, they can ignore market share, but nobody has closed formularies hardly because they're the least popular among patients for obvious reasons. So market share is a factor. And then you have to look at impending patent expiration. Because if you put a drug off formulary, in theory, you're moving people away from that drug. But if 3 months from now that drug is going to go off patent and it's going to become a generic drug, the last thing you will want to have done would be to have moved people away from a drug that's about to become way cheaper. So you have to look at impending patent expirations as well. And then, of course, look at rebates. So in this example, drug A offered a pretty significant rebate. And they did that because they don't have the market share. So they know the PBM can move against them and not hurt anybody. And if they only put one drug on the formulary for drug B, then the PBM gets a bigger rebate on drug B. Drug B wants to be the exclusive drug on your formulary and will give you the biggest rebate if they can get that. So drug A knows you're in that situation. And despite their higher clinical value, they know they've got to make a business case for you to put their drug on formulary. So drug A, despite being the best clinical drug, will probably offer a significant rebate. Drug B will offer a rebate because they want you to be in the game, but they have so much market share that they don't have to offer you very much of a rebate. And because they know it's hard, not impossible, but hard for you to walk away. Drug C, they got nothing going on. So they want to give you the biggest rebate because they want to convince you to be on market. Notice that they're still more expensive than A and B, but that's because they know that you, the PBM, get to keep a hidden percentage of that rebate. So even though they're more expensive to the patient, perhaps, and to the insurance company, the rebate confounds this whole thing about how the formulary gets built. Makes very conflicted interests. So when you're, in theory, designing this theoretical formulary, the smartest way is to start in the upper left-hand corner and just move down to the right-hand corner, depending on how much market share you feel like you need to capture without creating too much disruption. So that's kind of how that works. So what if drug C was still a crummy drug and still expensive, but had captured all the market? Maybe it was the first one on market. Maybe they just decided to pump more money into advertising. For whatever reason, drug C has really limited clinical value compared to the others, but has acquired all the market share. And for those reasons, and for the market share reasons, is able to demand the highest price. So if you don't add drug C to the formulary, then you don't get a contract, you don't get a discount, you don't get a rebate, and you pay the full retail price. That's kind of the point that I made. So there's pressure to put it on the formulary. So your market share can command your placement, except in closed formularies. Get that? That's how formularies are kind of built, except in Medicare, where it's a little bit more confounded. Part D, when Medicare Part D was enacted, with strong influence from the pharmacy manufacturing industry, they created these protected classes. So first of all, they identified 57 categories of drugs from which at least 2 products must be included. 57 categories of drugs from which any formulary must include at least 2 products. So that right away sort of tells a manufacturer that they're not going to get an exclusive position, but that changes the dynamics quite a bit. And then in 6 protected classes, they have to the Part D plans have to cover virtually all of the drugs in it. So if you're a manufacturer and you're negotiating with the PBM or the Part D plan, and you're manufacturing a drug from one of these 6 classes, you don't have to give much of a discount, if any, because chances are they're going to have to cover your drug, whether you give them a break or not on price. So, why are there these protected classes? Because these are sort of fragile patients in many ways. They're not quite as fragile as this law sort of created. There are other strategies where you can deal with this, and the best other strategy is what's called grandfathering, where if somebody is on a drug, it's a sort of maybe there's a better word, grandparenting. I've never heard it said like that. But if somebody is on a drug from one of these classes, you could simply make the rule be that they have to continue you on that drug and that they can't change the formulary on you. If you come into the Plan D, Part D plan on one of these drugs, they have to continue that. They can't move you off of it, and it's only new starts. So that would be more elegant. That was sort of a thing that I used to fight for all the time in my past life. So there's other ways, but and also understand that the pharmaceutical manufacturers are very good at funding and organizing, creating and promoting and amplifying messages from what seem to be consumer-centric advocacy movements. I've had some really weird experiences with that. So there's that. The advantage of having these things, these covered protected classes, is of course you get the broadest menu of drugs for patients and physicians. Hooray! The problem is, of course, the pharma knows that there's no BATNA. So I would say that there's a lot of other ways to deal with the problem that this is intended to solve, like exception criteria or grandfathering. Okay, changing topics for a moment. How new are drugs? How do drugs get to market? So a new brand drug starts with a new drug application, NDA, a new drug application submitted to FTC, I believe it is. So they file that on one day, and then once that gets approved, their patent starts. So their patent starts through FTC, of course, issues the patent. It's not the FDA that issues a patent. So their patent is 20 years long. But then, that doesn't mean the drug can go on market. FDA controls whether a drug can go on to market. And the amount of data required to get a new drug application and patent approved is completely different. The kind of data is completely different. You just have to prove you've got a unique product. You don't have to prove the product does what you think you want to do. It doesn't have to be proven to be safe and effective. None of the stuff that you would want for a drug to get on market. But to get a patent, that starts from the 20-year clock. And then FDA requires clinical data of various ranges. And then once FDA has approved it, then the drug can get launched in the market. So this process of getting the clinical data, the patent happens as quickly as they can get the patent submitted, because they don't want somebody else coming in with the patent. So they want to get the patent in before they've got the clinical data done so that they can protect their intellectual property. But that 20-year patent is not how long they have on the market. That doesn't get extended by the process of getting through FDA. So the actual real life of the drug under patent protection, without any games, and there are many, without any games, the actual patent real life experience of a drug on the market is more like 5-7 years or something like that. So then the Hatch-Waxman Act happened because it was before Hatch-Waxman, this law in 1983, before Hatch-Waxman, if you wanted to produce a generic drug, you had to actually do the studies to recreate the clinical proof of your drug. You had to do all the research recreating that this drug is safe and effective. That's really expensive and really slow. So there really wasn't much of a generic drug industry at that point. Hatch-Waxman happened in the early 1980s and gave the FDA the power to approve a generic equivalent of a brand drug if it's chemically identical, important, dose identical, not like Brisdell, but dose identical. And then all they had to do was do the sort of pharmacologic studies showing that the absorption, the area under the curve, the half-life, and the way it's all of that stuff. They had to show the pharmacology was identical to the brand drug. They didn't have to recreate the clinical data. So that's a lot cheaper. That's a lot cheaper, and it's a lot faster. And that's what created the generic drug industry. And every generic drug manufacturer has to recreate that kind of data for their drug to get approval by the FDA to come on market. But that's nothing near as difficult as getting a new brand drug to market. So all of these steps, every one of these steps, there are opportunities to influence how these steps go. I'm not going to do a robust unpacking of that. One thing I want to point out, I consider this the law of unintended consequences. So look at the price of new drugs. The price of new drugs was relatively flat, let's say from 2009 to maybe 2013, and then fairly flat for several years. Now, the last 3 years, the price of new drugs when they first get onto the market has been shooting up. Why is that? it's in part because of this. The Inflation Reduction Act uh, was really good at limiting how much a drug's price can go up after it's on market. After it's on market. So it didn't influence what you could charge for new drugs. So if you look back at the 2013 bump in new drug pricing, I was that's in part because people were expecting regulations that were going to do this, and that didn't happen as much. But the IRA influences how much you can raise a price once a drug is on market, and the manufacturers know that means we got to get in hot and heavy right at the beginning. So not intended. Another strategy that pharma uses is called PDUFA. It's my second acronym for you today, which is pronounced as a word, even sillier sounding word, PDUFA. That's what they say. And now we're on PDUFA 7, just to get it more granular. That's the Prescription Drug Users Fee Act. Prescription Drug Users Fee Act. And this is pretty important. So before 1992, PDUFA didn't exist. And if you wanted to get a drug on the market, getting through the FDA process after you'd sent in all of your clinical data, that took about 2 years. It took about 2 years. And so that was right when new HIV drugs were emerging, and people were rightly furious that all the clinical data was there to prove that these new HIV drugs were safe and effective, and yet they were languishing on the shelves in the FDA, not in small part because some folks in Congress had managed to successfully sort of shrink the bath, shrink the water in the tub so that they could. FDA was becoming increasingly underfunded to create an opportunity for industry to pay for it. So PDUFA was enacted in 1992 and meant that industry can pay for new drug approvals. And if industry pays for new drug approvals by this user's fee, that the approvals occur much more quickly. And they can even pay bonus round and get drugs approved even more quickly. So maybe that makes sense. Maybe that makes sense because FDA's we'd already lost the fight, and FDA had become so underfunded. So maybe it made sense to let them pay for pay to play, so to speak. So then, before 1992, FDA's money was entirely public, and that's no longer the case. It's no longer the case. So now, pharma funds most of the FDA's human drug division. Now, FDA will tell you, and industry will reiterate it, that there is a church-state separation, that there is no influence from industry on FDA. So, hooray, I'm glad and reassured to hear that. But they would tell you that. But the fact of the matter, follow the money. 75% of FDA's new human drug division is funded by industry. This is relevant to you as potential policy wonks in the future. PDUFA it sunsets every 5 years, and so we are now midway through PDUFA 7. And I think you'll hear from Joel in a couple of days when he talks about solutions. I think he's going to say that I'll say if he doesn't, but that we should eliminate PDUFA. We should just completely fund FDA through the public forces. This is not a good public-private collaboration. That should be just publicly funded. There's no campaign to do that. There's that's not anybody's top priority. It's not but. I'll give my little 1-minute soapbox. I think we should publicly fund FDA and get rid of PDUFA. So last major part of pharmacy, I think, is specialty drugs. These are drugs that are typically created in large bioreactors, not in little test tubes of mixed chemical A and chemical B, and voila, you've got a drug that can help people. These are specialty drugs are typically large, complex, gloppy molecules produced in living tissues. So the notion here is that if you're looking at an aspirin, if that were a bicycle, a small biologic would be a Prius, and a large biologic would be an F-16. These are huge, three-dimensional, complex messes that you can't just write a simple chemical formula for. You have to write, so the patent isn't a simple chemical formula like it is for the traditional pills and their generics. The patent is about the process of creating it with hamster ovary cells or whatever it is. So it's hard to think of how you can't just, recreate the drug in a test tube and then do the pharmacologic studies and show that it has the same effect. You can't do that because it's not chemically identical. It's not going to meet those criteria. And these drugs are now dominating pharmacy. They, in a way, 98% of Americans do not take one. So they're not really dominating, but they represent the majority now. We've crossed the Rubicon. They represent the majority of what we spend on prescription drugs. So if you are looking at ways to manage prescription drugs and all you're thinking about is traditional brand and generic drugs, you're actually missing the big picture. You're actually missing the big picture because the bigger part of the money is on these complicated molecules for which you can't have a generic, so generic drugs were a great strategy when it was a small part of the market. That's no longer the case. So instead, since you can't have generics, there's this thing called biosimilars. When this was first starting, we were kicking around the word biogeneric, and we realized that was a stupid word because they're not generic. So now the word is biosimilar. They're biologically similar because you can't make the same thing, unless you have that company's hamster ovary cells in a very similar bioreactor. So biosimilars, much more complicated. So, but not impossible, not impossible. So manufacturers have these, the traditional pills have, 5 patents, 3 patents, very few, maybe some games there, but these biologic drugs, they may have hundreds of patents and they overlap. And so when Yep, and you can't produce a similar product until all of those patents have expired, and they're in waves, and it's a big mess. And then, in addition to their patents, they have a separate pathway to get market exclusivity and data exclusivity. Because remember, I said that the generic drug has to show that it has the same pharmacology. So you need the data to show that it has the same pharmacology, and there's rules about when a manufacturer has to and doesn't have to release the data. So how do you fight against that? If you have a microphone for this sort of thing, it's good to have a cough button, which I do. So how do you fight? How do you fight against that? The first is there shouldn't be these hundreds and hundreds of patents, for a drug. There should be a more appropriate approach to patents, and I believe Joel is going to talk about that with you. The pathway to getting biosimilars to market has to be much simpler and much faster than it is yet, and we have interchangeability standards at FDA for traditional generic drugs, right? They have an orange book, I think it is, that says, here's 6 generic identical things that you can interchange. Pharmacist, you can dispense that generic if I write that brand. And those standards are just starting to emerge for biosimilars. Because, if you have to call me, it's going to screw things up. And you want to be able to have the pharmacist take some ownership over that process. So the last thing I wanted to tell you about this is a story that you probably didn't remember. It got kind of lost in the shuffle of stories. But to me, it's the cause for hope out of 9/11. So I thought it was worth kind of, making you aware of it. Remember, this is not the hopeful part. You probably remember or read about, because you're younger than I am, that one of the things that happened in 9/11, aside from the trade towers, was this whole scourge of anthrax being weaponized and mailed to people. Anthrax. So there were half a dozen of real events where anthrax was weaponized into a powdered form that then you could open an envelope and inhale it and get anthrax, which is a terrible disease to have. So Senator Daschle, for example, actually received one of these letters that had anthrax in it. So when that happened, there was this sense that, my gosh, this is a scalable attack. They could send letters to everybody in the country. There could be hundreds of millions of people that get anthrax letters. This is a big vulnerability. And hooray, there was a drug to treat anthrax, Cipro. At the time, not generic. Now it is ciprofloxacin, but at the time, in 9/11, 2001, it was only available as the brand drug. Cipro was the only drug of that category. So, hooray, that was there. So Cipro was produced by Bayer and was cost $560, which today seems like nothing, but compared to some of the stuff we see, but it was costing almost $5 per pill, $560 for the course of treatment you would need if you contracted anthrax. So 560 for a 2-month treatment doesn't seem like that much nowadays, but remember, we're talking about potentially needing to have it available for 100 million people or 200 million people. So it's a lot of money that we were talking about just on this one pill to prepare us for anthrax. So Bayer, a generic drug manufacturer here in the United States, said that, if you can get us to avoid the royalties that Bayer is going to demand of us, we could produce the drug for a fraction of what Bayer is offering it for. Well, that was pretty tempting. And Canada actually did that without Bayer. Canada used their laws, which we happen to have too. Canada used their laws to say, that's just craziness. We can't protect ourselves in that way. And so Canada did override Bayer's patent and ordered generic drugs of ciprofloxacin. So it turns out that we have the same power if we choose to. The Bayh-Dole Act in 1980 has many problems with it, but one of the advantages of it is that this does give FDA the ability to march in, is the phrase that they use, march in and authorize generic manufacturing of a drug if the brand drug that was produced with public funds, if there's a brand drug that was produced with public funds and is not being used in a way that serves the public good, it's roughly how the language says, then Bayh-Dole Act says FDA can march in and approve generics. So hooray for that. And as you know, almost all drugs are heavily funded by public funds, NIH. So hooray for that. We threatened to do that to them. We didn't actually do it. We threatened to, and somehow Bayer figured out a way that they could produce the drug for a fraction of the price. So hooray for that. So why am I telling you this story? I'm telling you the story because there's all these overwhelming problems, but I think there's sort of a hopefulness to this, that we have the tools to do this. We just have to decide to use them.